Hi, my name is Shah. I'm the Director of Breast Radiation Oncology and the Director of Clinical Research at the Cleveland Clinic. Given updated data on intraoperative radiation therapy, a key question is who is eligible and appropriate for the use of intraoperative radiation? When thinking about intraoperative radiation, it's important to recognize that there are two unique techniques. One technique uses low energy X-rays, commonly 50 kV photons, and is commonly called target therapy. The other intraoperative radiation therapy technique uses electrons with different energy choices available and is often referred to as Elliott. In the last year, we've seen updates from two randomized trials, the Target A trial as well as the Elliott trial, presenting long-term outcomes with the use of intraoperative radiation therapy. With respect to the Target A trial, this trial used low energy IORT. Over 3,000 women were randomized to IORT or whole breast radiation. Importantly, the IORT group had two subsets in it. One group of patients who received IORT at the time of surgery, or known as the pre-pathology group, and one group of patients who received IORT as a secondary procedure, called post-pathology. This is important because of the two different ways the IORT was delivered, but also approximately 20% of women in the pre-pathology group got whole breast irradiation as well, while less than 5% received whole breast radiation in the post-pathology group. The initial 5-year outcomes from this study were published in 2014, and with 2.5-year follow-up, demonstrated an increase in local recurrence with IORT, though it was within the 2.5% non-inferiority threshold. It was roughly 3.3% versus 1.3%. At that time, concerns existed regarding the post-pathology stratum, as there was already an increased risk of local recurrence exceeding the threshold in that subset, which was not seen in the pre-pathology subset. In the last year, we've had two publications from the Target A trial. Unfortunately, the investigators have not provided data for the entire IORT subset, so it's unclear what long-term outcomes are for this entire population. With respect to the post-pathology subset of patients, these patients were found to have increased rates of local recurrence exceeding the non-inferiority threshold of the trial, and therefore this was not recommended as a technique to be utilized. With respect to the pre-pathology group, the data is difficult to interpret. At 5 years, local recurrence was within the non-inferiority threshold, but was increased compared to whole breast radiation. However, long-term follow-up did not provide with data on local recurrence, as the authors used a composite endpoint of local recurrence-free survival. Additionally, the authors did not provide data on the rates of local recurrence with IORT alone. When evaluating this pre-pathology manuscript, it does appear that there's a 2- to 3-fold increase in local recurrences based on the number of recurrences, but we were unable to really evaluate what the long-term local recurrence rate with IORT using low energy is based on this update. With respect to electron IORT, the Elliott trial recently presented long-term follow-up in an article in The Lancet. This trial looked at electron IORT as compared to whole breast radiation, but did not offer whole breast irradiation for the electron arm, unlike the Target trial. Unfortunately, with long-term follow-up, the rates of local recurrence with the Elliott technique exceeded 10% as compared to around 2% with whole breast radiation. Of note, there was no difference in survival and no toxicity data provided, but this drastic increase in recurrence, particularly in light of other partial breast techniques available, raised concerns. So in summarizing, we have two randomized trials demonstrating increased rates of recurrence. And so the question is, who's eligible? At this time, based on guidelines from the American Brachytherapy Society, neither low energy or electron IORT should be recommended outside of prospective studies, while the ASTRO guidelines, which were published prior to these updates, only allow for electron IORT in good risk patients to be offered off trial or off study at this time.